Namaste. My name is Chandra-Mouli. I worked for the World Health Organization from 1993 to 2023. For 27 of these 30 years, I worked on adolescent health with a particular focus on adolescent sexual and reproductive health and rights. I continue to work on these issues on my time and on my terms. This short presentation is about adolescent pregnancy and childbearing. Globally, the adolescent birth rate has decreased. In 2021, it was estimated to be 42.5 births among 1,000 girls aged 15 to 19. Despite this decline, an estimated 12.1 million girls aged 15 to 19 gave birth in 2021, and an estimated 499,000 girls aged 10 to 14 did so in the same year. There are two other points to note. Firstly, the rates of decline and the levels differ between world regions, between countries in each region, and between provinces and districts in countries. So progress has been uneven. And secondly, although the rates of adolescent childbearing have declined, the absolute numbers of girls who bear children during adolescence are still high. And in some parts of the world, notably in sub-Saharan Africa, because of a large and growing population of adolescents, the number of adolescent births is actually still increasing. Several factors contribute to adolescent pregnancies and childbirths. I'm going to mention three groups of factors. Firstly, in many societies, girls are under pressure to get married early and to bear children soon after marriage. Such pressures exist even in contexts where child marriage doesn't occur, but informal unions occur. Even where there is no pressure on girls to marry or to enter into unions, often early union and childbearing is the best of a limited set of options for girls because there are very limited educational and employment opportunities for them. Secondly, adolescent girls are much less likely to use contraception than adult women. There are a number of reasons for this. Firstly, they may not be very well informed about adolescent contraception, given that in many places sexuality education programs either don't exist or do not address contraception. Secondly, they may have misconceptions, notably about return to fertility. What this means is that they may believe that if they use contraceptives, they may not be able to have children later on. Thirdly, they may not be able to negotiate contraceptive use with their partners. Fourthly, they may not be able to get the contraceptives they want to because of legal restrictions, financial restrictions, or social taboos. Of course, the practical issues in terms of where to get them and when to go are also issues that are barriers to adolescent girls. So overall, there are a number of barriers for adolescents to obtain and use contraception. And thirdly and lastly, we know that levels of intimate partner violence and sexual violence are high in adolescent girls. Unintended pregnancies, unwanted pregnancies are much more likely to occur in these contexts, in the context of sexual abuse, in the context of physical or psychological coerced sex. So a multitude of factors contributes to adolescent pregnancy and childbearing. There's been awareness of the negative consequences of early pregnancy and childbearing for over 50 years. There's awareness of the need to address it, but this issue did not get the attention it deserved till it was placed on the global agenda in the context of the International Conference on Population and Development in 1994. 6 years later, in the context of the Millennium Development Goals in 2000, adolescent pregnancy prevention was on the agenda. But for the first 10 years of the MDG era, adolescent pregnancy was not addressed because it was not considered a priority. There were many other priorities. In the last 5 years of the MDG era, efforts to reduce child marriage, a major contributor to adolescent pregnancy, and to increase access to an uptake of contraception and to provide them with sexuality education were initiated and began to gather momentum. In the Sustainable Development Goals, which were formulated and then implemented from 2015, adolescents are at the center of the agenda. Adolescent pregnancy too is at the center of this agenda, both globally and in regional agendas, such as those of the African Union and the South Asian Association for Regional Collaboration. There's been a huge amount of progress. For years, non-government organizations have led efforts to prevent adolescent pregnancy. From their projects and from research studies, there's a growing body of research evidence and programmatic experience on what it takes to reduce adolescent pregnancy and childbearing. Until recently, these proven approaches have been applied only in a limited way, in small-scale projects, in time-limited projects, in piecemeal projects. Despite governments identifying adolescent pregnancy as an issue and placing it on agendas, actual implementation has not really taken place in many places because of lukewarm commitment, because of lack of capacity, particularly in the government sector, and because of lack of any real accountability for implementing activities and for demonstrating results. However, a small but growing number of countries have broken the mold and put in place government-led, large-scale and sustained programs which over time have demonstrated results in adolescent pregnancy prevention. In this just published book, we have worked with experts from 5 countries: Argentina, England, Ethiopia, Moldova, and Thailand, to document what they did and to document what results they achieved. Each of these case studies is described in this book, but there are some common threads that emanate from their work. 5 points. Firstly, they put scale-up of adolescent pregnancy prevention on national political and governmental agendas. Secondly, they planned scale-up meticulously. There's a menu of approaches, but they chose what to do, which was feasible and which was acceptable in their contexts, and they developed a package of actions which needed to be scaled up. They raised resources, in some cases almost entirely from within, in other cases from both within and outside the country, and used these resources well to implement and manage the implementation of large-scale programs. They built community support, societal support, and when resistance and opposition occurred, they addressed it in a systematic manner and helped overcome it. And then they worked strategically to sustain these efforts, because these efforts take time. In every country, it has taken 3 to 5 years to demonstrate results. In each of these countries, tangible progress has been achieved in reducing child marriage where levels were high, in increasing access to an uptake of contraception, and in reducing rates of adolescent fertility. Having said that, there is still unfinished business. While some groups of adolescents have benefited, others have been left behind, and they need to be addressed. The experiences of these 5 countries and many others that we have not documented in different social, cultural, economic contexts demonstrate clearly what can be achieved with the application of good science combined with bold leadership and strong management. I want to end my presentation on a positive note with some information about one of the 5 countries that I mentioned earlier. One of these 5 success stories, and one that is really exciting to share, is Thailand. In Thailand, the rates of adolescent childbearing increased substantially during the early 2000s. The government of Thailand decided to act and took decisive action. They first worked to learn what had been done by other countries. Then, based on that, they developed a plan of work and then started to take decisive action. Central to the progress made is the recognition of the rights of young people as enshrined in a groundbreaking Adolescent Pregnancy Act. The Act was approved by Parliament in 2016, and enactment began soon afterwards. Of course, activities had already begun. A national committee chaired by the Prime Minister was established, and 5 subcommittees were set up in line with 5 components of the national strategy. First, providing school-based sexuality education. Secondly, involving families and communities in efforts to reduce adolescent pregnancy and childbearing. Third, improving the quality and improving access to sexual and reproductive health services and other health services. 4, developing support and welfare systems for young pregnant women and their families. And finally, for improving data collection and knowledge management. So 5 broad lines of work. Now, what characterizes the Thai approach are 5 points again. A clear recognition of the rights of adolescents enshrined in a national law and translated into programs. A multi-sectoral approach with clear roles for each sector. The empowerment of local authorities to carry out actions tailored to local realities. The setting of goals to halve adolescent pregnancy in 10 years and developing policy strategies to achieve those goals. And modeled on the UK example, the establishment of an independent advisory group to guide and oversee progress. In Thailand and elsewhere, there is unfinished business. Progress has been made, but there's unfinished business. And in Thailand, it is to achieve national coverage and to assure quality of implementation and to ensure continued support for this work, and when resistance and discomfort occurs, to understand it and to respond to it in an empathetic manner. With that, I end this presentation. My message, the central message from my presentation, is that rates of adolescent pregnancy and childbearing have come down steadily over the last 25 years. It is part of the global agenda. It is part of the national agenda in many countries. But it is still not being addressed meaningfully in many other countries. Reducing adolescent pregnancy and childbearing is not a guessing game. There is science. What it takes is commitment and translating this commitment into meaningful and concerted action to achieve results. Thank you and namaste.